Swiss Liver Patients Association, Swiss HIPAA. Today with the presentation by PD Dr. Christoph Jüngst, Senior Physician at the Clinic for Gastroenterology and Hepatology at the University Hospital Zurich, with the topic Drug-Induced Liver Injury, DILI. Welcome, Dr. Jüngst.
Thank you very much for your kind invitation to give a talk on drug-induced liver injury. Drug-induced liver injury, or DILI, is a rare event. It is difficult to anticipate and to diagnose, and there is a wide range of clinical presentation. Many patients present with only mildly or moderately elevated liver enzymes, but there is the possibility of a progressive disease, even to acute liver failure. DILI is also an important reason why drugs have to be taken off the market or they don't get licensed at all. How often is DILI? For most drugs, it's quite rare, with an incidence of only 1 to 10 to 1 to 100,000. But if we have a look to some specific populations, like patients which are hospitalized in internal medicine, there is a work from the Department of Internal Medicine of the University Hospital Zurich in Switzerland, where there was an incidence of DILI of 1.4% of all hospitalized patients. In an outpatient hepatology clinic in Sweden, the incidence was 6.6%. There are two prospective population studies, one from France and one from Iceland. The study from France showed an incidence of 14 on 100,000 inhabitants, which was much higher than expected. And the study from Iceland showed even an incidence of 19 on 100,000 inhabitants. About a quarter was jaundiced of these patients, 20% needed to be hospitalized, and one case was fatal. We conducted a survey study with pharmacy customers. About 1,000 pharmacy customers took part in the study. Of these, 141 said that they had experienced an episode of DILI. 65 needed to stop the medication, and the 20 patients even needed to be hospitalized because of DILI. All these data show that DILI is rare. However, it is occurs much more often than we thought before. When we are taking drugs, there are different reactions. Most patients are tolerant to the drug. Some adapt to the drug, and some patients experience a persistent elevation of mildly or moderately elevated liver enzymes. These patients have a mild DILI. They may be symptomatic, and some patients progress to a really severe disease, to acute liver failure. Acute liver failure is very rare, with an incidence of 1 to 6 of a million inhabitants a year. However, the etiology is major cases drug-induced. In the US, up to 50% of acute liver failures are due to drug-induced liver injury, and in Europe, 17 to 50%. In the US, the major drug involved in DILI is paracetamol, because it's an over-the-counter drug and it's sold in really large units. In Europe, the most important drugs are antibiotics, especially amoxicillin clavulanic acid and NSAIDs. We have two different mechanisms of injury in drug-induced liver injury. One is the intrinsic or direct mechanism. The other one is the idiosyncratic mechanism. With the intrinsic mechanism, the toxicity is predictable. It's dose dependent. That means that we need an overdose of the drug to get the toxicity. And the toxicity starts quite early, within the first week of intake of the medication. And the major medication or major drug of this intrinsic mechanism is paracetamol. On the other hand, we have the idiosyncratic DILI, where the toxicity is not predictable. It's not dose dependent. That means when patients are taking a regular dose, regular drug, then even then DILI can occur. We don't need an overdose. And the latency, that means the time when you start the drug until DILI occurs, is very variable. We have two subtypes, immunologic and non-immunologic DILI. In immunologic DILI, the latency is mostly 1 to 5 weeks, whereas in non-immunologic DILI, latency can be very variable between 1 week and several years. However, it's mostly between 1 and 6 months. Patient with immunologic DILI can have or show fever, exanthema, or lymphadenopathy. Paracetamol is by far the most important drug for intrinsic DILIs. Therefore, I want to go into more detail of the pathophysiology. When taken in regular doses, paracetamol is mostly metabolized to non-toxic compounds, to glucuronides and sulfate metabolites. Only some parts of the paracetamol are metabolized via cytochromes into a toxic compound, the so-called NAPK, and this toxic compound can then be detoxificated via a glutathione-dependent pathway into non-toxic compounds. When we have an intoxication of paracetamol, we get much more of the toxic metabolite, of the NAPK, and this has to be detoxified via this glutathione-dependent pathway. When glutathione storage is empty, then we have a lot of this really toxic compound, which leads to then cell injury and hepatocyte necrosis. The single toxic dose of paracetamol is about 150 milligram per kilogram body weight. These single doses are mostly taken in attempts of suicide, but also when you take lower doses and repeated days on several days of 4 to 10 gram, which is above the recommended dose, but it's lower than 150 milligram per kilogram body weight, this is already sufficient to get toxicity. In conditions of chronic liver disease, for example, liver cirrhosis or malnutrition, anorexia, or chronic alcoholism, already lower doses are sufficient to cause liver injury. Clinically, we have 3 different phases. Initially, we have less symptoms. The patient feels a bit fatigued, some gastrointestinal complaints, and after about 20 hours, he even feels better. However, then we have a rise of the transaminases and the bilirubin, and after 3 to 4 days, we will find liver and kidney failure. The patient clinically has hepatic encephalopathy, which can progress to consciousness to coma. For making the diagnosis, it's very important to take a patient history, and we detect the paracetamol levels when the patient is hospitalized. Most of the patients are treated on an intensive care unit. They receive activated charcoal for decontamination, and there's a very important preparation, the N-acetylcysteine, which has to be given intravenously as soon as possible, because via the N-acetylcysteine we provide sulfhydryl groups which help to detoxify this toxic metabolite, this NAPK. When N-acetylcysteine is initiated early, then the therapy is most often successful and we can avoid liver transplantation. The pathophysiology of idiosyncratic DILI is very complex. Drugs are most often metabolized in the liver and then cleared via the kidney or the hepatobiliary system. During metabolism, we get reactive metabolites which may cause cellular damage, such as oxidative stress or mitochondrial damage, bile acid accumulation. And when there are no adaptive processes, this cellular damage can initiate immune response, which can also be initiated by the drug itself, and then trigger inflammation, which causes liver damage. Clinically, patients mostly have only mild symptoms like nausea, vomiting, some abdominal pain, or fatigue. They may have systemic hypersensitivity in immunologic DILI with fever, rash, or lymphadenopathy. And when they progress to really severe liver disease, to acute liver failure, we find jaundice, hepatic encephalopathy, coma, and multi-organ failure. DILI can be classified according to the pattern of toxicity. We have the hepatocellular pattern with a dominant rise in transaminases. We have a cholestatic pattern with a rise of the alkaline phosphatase. And then there's a mixed pattern where we find elevation of transaminases and of the alkaline phosphatase. The different drugs can be assigned to these different toxicities. There are drugs which in the majority cause a hepatocellular profile of toxicity. Some cause cholestatic toxicity, such as amoxicillin clavulanic acid. And there are drugs which cause a mixed type with elevated transaminases and alkaline phosphatase. However, there are also drugs which can cause hepatocellular injury and cholestatic injury. So not every drug has really a clear signature of toxicity pattern. Which drugs can cause DILI? In principle, there are numerous drugs which can cause DILI. But some are more important than other drugs. We have data from registry studies, and these studies show that the most important drug class causing DILI in these studies are antibiotics. And the most important antibiotic is amoxicillin clavulanic acid. The second important drug class are NSAID, followed by CNS drugs. Diagnosing DILI is quite challenging. It's very important to take a careful patient history, to ask for the drug or also for herbals which the patient may take, and to ask for the latency time. That means the time from the first intake of the drug and until DILI occurred the first time. The patient may have allergic symptoms, such as fever, lymphadenopathy, or we find eosinophilia. Other liver diseases have to be excluded. That's very important to exclude, for example, viral hepatitis, autoimmune hepatitis, or cholestatic liver disease. And we have to do a lot of lab works with viral serology studies, autoantibodies. We need to do an ultrasound of the liver, and in some cases, even do a liver biopsy. Then we have to see if the patient has more a toxicity pattern which is hepatitic or cholestatic, or if it's a mixed type pattern. A hint for DILI could be when the liver enzymes are falling after stopping the medication, possibly only within time. A problem might be when the patient is taking several drugs, which could potentially cause DILI, and we don't have a specific biomarker of a drug. So this could really be a puzzle to figure out which drug could be the one who caused DILI. Therefore, we have to do a lot of literature research, or also to consult a website which is called LiverTox. It's the website of the American NIH, and you will find there more than 600 substances and a lot of information about the pattern of toxicity, about latency, incidence, disease course, disease severity, really a lot of information. And this website is highly recommended when you deal with patients with DILI. For prognosis of DILI, there is one important law, which is from the 70s, but we still use it. It's called Hy's law, because it was established by Hyman Zimmerman, a very famous American hepatologist. And he finds that when the transaminases are elevated more than 3 times the upper limit of normal, and the bilirubin is elevated more than 2 times the upper limit of normal, then we have a really high mortality of the patient of 10 to 50%. In other words, if you have hepatocellular DILI and the patient is jaundiced, this is really then crucial because we have high mortality rates. This recent research on new biomarkers for DILI, for example, some markers of cell deaths or some specific bile acids, and to get a better impression of the prognosis of DILI. And also the University of Zurich, the Clinic of Clinical Pharmacology and Toxicology is involved in these studies. For example, in the Pro-Euro-DILI registry study TransBioline, which is a multi-centric European study, and interesting data is really awaited in the future on prognostic biomarkers in patients with DILI. When we are talking about risk factors for DILI, we can think, where could they be? There might be risk factors in the drug itself. There might be some environmental factors, or there could be genetic factors, which could be risk factors for DILI. And indeed, it was shown that drugs which generate a lot of reactive metabolites during the metabolism, drugs with a higher mitochondrial toxicity, drugs which are metabolized in the liver, on drugs with a daily dose of more than 50 milligrams, and drugs with a lot of drug-drug interaction with cytochrome induction, that these drugs have a higher likelihood to cause DILI. There are some patient factors or environmental factors like age, gender, chronic alcoholism, other liver diseases, or co-medication, which have to be taken into account for the risk for DILI. And there are some genetic factors in genes of the drug metabolism, of detoxification, of transporters, and also in genes of immune response, especially in the HLA system. This shows you that it's really very complex. There is a very individual risk profile. It is dependent on the specific drug which is given, and it's really very difficult to predict which patient will get DILI after taking a drug. The DILI therapy is quite simple. The major step is to stop the medication, but this has to be done in discussion with the caretaking physician. This is very important. We have some specific cases with, for example, paracetamol intoxication, where we have some specific intervention. As we heard, we give N-acetylcysteine very early in the disease course. Then DILI caused by checkpoint inhibitors, which are nowadays quite often used for the therapy of different cancers. In these severe DILI cases, sometimes steroids are needed or other immunosuppressives. Also, steroids are needed in DILI with signs of autoimmune hepatitis or with hypersensitivity reactions. DILI should be reported. In Switzerland, the healthcare professionals are obliged to report DILI to Swissmedic. Also, patients themselves can report DILI. However, I would recommend that they discuss this issue with their doctor and that he is the one who is reporting it to Swissmedic. You will find a lot of info on it at the website of Swissmedic in the area of the pharmacovigilance. In conclusion, DILI is a rare event. However, the incidence might be underestimated. For getting the diagnosis, it's very important to take a careful history, also including herbals, and ask for the latency. You can consult the website LiverTox, which will help you to find out which drug is the one causing DILI. Other liver diseases have to be excluded. The risk is very individual and it is hard to predict which patient gets DILI. Prognosis can be estimated by Hy's law, which says that when transaminases are high and the bilirubin is high, then the mortality is high. The main step in therapy is stopping the medication after discussing it with the caretaking physician. And in some cases, you will need steroids, and DILI needs to be reported to Swissmedic. Thank you very much for your attention.
Thank you very much for the informative and exciting presentation by Dr. Jüngst and your great personal commitment. Thank you very much.